Welcome everybody to our seminar on soft power in the clinic. And I'm Carl May. I'm a sociologist at the London School of Hygiene, and I co-lead the Innovation and Implementation Science research theme in North Thames Arc with my colleague Fiona Stevenson. So today we're going to talk about power. It's important. It's not often addressed, and it matters a lot in implementation research. It's fundamental to understanding almost every aspect of healthcare, and inequalities of power and knowledge run through almost every kind of healthcare interaction. So today's seminar on soft power, the power that's inherent in relationships, the power that's inherent in knowledge and practice, is going to explore how power can help us, or how an account of power can help us understand the adoption and implementation of healthcare innovations and the configuration and reconfiguration of health services. So we've got some fantastic speakers today. Sarah Knowles and Lynn Laidlaw, who are going to kick off for us in a moment. Sarah's a world-acknowledged expert on knowledge mobilisation, and she's on the staff of the University of York. Lynn Laidlaw is one of the UK's leading advocates for patient and public involvement and engagement in healthcare research and practice. They're going to talk about how academic debates about power and can exclude patients, and offer some thoughts about how to remedy that. Lorelei Jones is a brilliant anthropologist. She's on the staff of Bangor University. She's going to talk about the path-breaking work that she and colleagues have done about how power is mobilised and mediated in the work of medical directors in hospitals. And Justin Waring is Professor of Medical Sociology and Healthcare Organisation at Birmingham. Justin's a leader in work at the intersection of medical and organisational sociology, and he's going to talk about the political moves and games through which implementation gets realised. So we're very fortunate to have these four brilliant speakers today, and we're going to see, I think, internationally outstanding work and research. Okay, well, without further ado, let's begin. We have Sarah Knowles and Lynn Laidlaw, who are going to talk about patients and power.
Yeah, hi everyone. So I'm Sarah Knowles. I'll let Lynn introduce herself in her section of the talk. We're going to try and split it to about 20 minutes each. Ideally less for me, as I'm the most boring part of this duo. So we're here to talk about power and patients in the clinic. And to give a kind of capsule summary, when Carl invited us to this talk, and we asked him kind of what kind of things did he want us to discuss. And he said the question he kind of posed was, how do patients and public contributors negotiate and manage kind of power with different clinicians, with health professionals, with researchers? And for both myself and Lynn, I think the response was, what power would that be that patients have? And Carl, to his credit, said, great, talk about that. So that's what we're here to talk about. And you'd certainly be forgiven for thinking that patients have power in these settings and these situations, because the narratives of empowerment are really very common, but actually we would argue they are quite superficial, and if anything tend to obscure the fact that patients don't have power in these situations. And we want to kind of take the opportunities to reflect that back on ourselves as well. We want to talk about how in these settings, in these kind of academic rooms where the great and the good come to discuss power, are they open to patients? Are they accessible? Or are they another way of kind of excluding people from a dialogue that is about them? what I want to start with is that my main kind of discussions with patients about power have been as part of a knowledge mobilization fellowship I did, which looked at the role of patients in something called learning health systems. And the simplest way to understand that is a learning health system is the idea of using routine data to identify improvements and drive improvements. So it's about cycles of improvement. It's about, rapid implementation. And we wanted to look at how patients themselves could play a role in that. And all of the literature on learning health systems talks about patient-centered learning health systems. So you think, okay, that's good. That sounds good. Good start. But I said that to the group of public contributors I work with, and they immediately groaned and rolled their eyes, because to them, that is an immediate red flag. That means patients are put in the center. So think about who is active and who is passive in that, who's getting put to places, whether they want to or not. And that actually being in the center can be a way of being isolated. They're kind of in the center with all the things happening around them and about them, but they're not actually having any power to influence that themselves. We did an exercise in that project quite early on called dark modeling, which is basically, it's a reverse way of trying to imagine what you want out of a system is to imagine the worst possible system. Essentially, it says, let's lean into the kind of cynicism that we all have about planning for these things. And if you can see that, everything that came out of that exercise from the patients when they were doing this dark model was about power, or about being excluded from power, about being ignored, about being left out of decisions, about them and us attitudes, about jargon, language being used about them that they couldn't understand, about hierarchies. So power was just really immediately core to what they wanted out of a system. If they didn't have power in that system, how could they be expected to support it? Or even to endorse it. And as we kind of explored this more, we realized that this was unfortunately pretty common, particularly in this area of the role of kind of data and data-driven improvement and big data. All of the narratives about that tend to adopt this very participatory language. They tend to talk about, that people will then be able to get onto their iPhone and contribute data, and that will be a way of empowering them, which kind of neglects that that's actually really positioning them as just kind of there to donate data rather than actually having an active role. And where there have been sort of engagement events with patients and the public about some of the more controversial issues, some of the issues about the trust in data and who has access to data. These evaluations here have shown that really they've been about kind of calming the controversies, trying to kind of put that down and put it back in its box, rather than actually being an authentic opportunity to explore what this means. And so what we find is that despite the language being about power, the differences in power relations aren't being acknowledged, let alone kind of challenged in any meaningful way. And to give another example in terms of service design improvement, so integrated care, big movement towards integrated care to deal with, for example, things like multimorbidity. And again, this is a fantastic paper by Glimmerveen and colleagues, where they sort of pull apart really the rationale that is put forward that patients are an active part of initiatives toward integrated care. They really point out that actually it's about the patients, the citizens being passive recipients of that care. And it's about whether they then legitimize the existing systems, the existing decisions made about them, rather than, again, there being any opportunity authentically to kind of debate these things, have an influence, think about them as having their own expertise and knowledge that needs to be blended with what's going on. Instead, they're used to fit in to existing things. And this is one of those things that once you've seen it, you can't stop seeing it. You start seeing across all of these different examples where the words talk about power or influence, but they are superficial at best. So you have, I really like this tweet. This was actually from a couple of years ago about an accidental lesson in demonstrating how the patients will be at the back of the room trying to raise their hands and get seen by the people making the decisions. But again, language really, really telling. So we have NHS England talking about people being empowered to participate, which is a bit of interesting linguistic trickery, I think. So you're empowered, but to participate in someone else's system rather than empowered to change things. This, I think, one of the most kind of hated words, harnessing the power of patients. And I feel like I don't need to explain that one. We know what a harness is used for, right? This is really not putting patients in a kind of active role as collaborators. This is about, again, quite explicitly using them for our own purposes. So that's a very negative take, I understand. So what can we do differently? What would it look like to do it better? So to go back again to my example from my fellowship, patients in the learning health system. So the patients didn't want to be in the centre. They didn't like that. That felt like they were left out. And as we talked about this, we realised that that idea of slotting in patients at appropriate points in an existing system had actually happened in this project as well. And that's on me. And, you know, I'm a cocky so-and-so who thinks I'm really good at PPI, and I got it wrong here. I had those assumptions in my head that actually you could take an existing idea of improvement cycles and look at where PPI would happen around it. And the contributors said, no, that's not good enough. Patients need to be the axis of this. They need to be the people making the decisions and things turn around them rather than being slotted in to accompany it. And that meant that they wanted the power to ask the questions themselves. And in that study, we actually changed the research questions to be what the patients wanted to ask instead. And that's how this needs to look, we think. But unfortunately, in research, it's the case that more often than not, they don't have that space to influence things, that space to change things. We unfortunately know quite a lot about how researchers manage power in patient involvement in research to keep patients away from influence and to prevent them from kind of exercising any kind of influence over decisions. So this absolutely fantastic paper, Olympic on a Ship, an ethnographic study of kind of meetings about PPI, and basically this exposes this issue again, that in the meetings we use agendas, we use reporting processes and research to justify why we can't possibly change things, okay, to essentially exclude the influence of patients and find ways to not let them direct things in the way that they think is important. The other key mechanism that researchers have to disempower patients in this setting, and this will be very familiar to any public contributors, is this idea of who is representative, that kind of the patients who are saying they want things changed, they're not the average patient, so we don't have to listen to them. And we did a study in the Greater Manchester Clerk, which we're writing up at the moment, where we found that this idea about being representative, the interesting thing is that patients don't see that as a point at all, because for them it's about diversity of viewpoints and about actively comparing and contrasting to find new knowledge together. So this idea that you would be representative is this kind of zombie idea. But we found that researchers very much draw on this when they're being challenged. When they're not being challenged, there's no question of people being representative, but it's essentially drawn out. It's wielded when patients try to change things. So we have this very problematic thing where patients are representative as long as they agree with us. And I guess that's where I wanted to say that with patient involvement, unfortunately, it's not that we're providing a better example which for improvement services and clinicians could learn from. We really are doing the same things. We have the same problems. And it's this issue of treating, in this case, patient experience as a thing that we can choose to either pick up and include in what we're doing or to exclude it. We want to include the patient perspective or the patient voice as if that's a singular thing. We don't want to actually talk to patients. That's the problem in a lot of these things. And to really kind of bring it meta now, bring it back on us, there's a challenge, a problem that exactly what's happening now can be that in action. It can be a space where people like me are invited to speak about patients instead of hearing from patients themselves. And we don't want to make that mistake. And that's why I'm going to pass you on now to, as I said, definitely the star of the duo, Lynn Laidlaw.
Thanks, Sarah, and thanks for the invitation. So I just want to talk about some personal reflections on power. And like a lot of you in the audience, I suspect I wear multiple hats because I'm here as a patient, because I have a rare autoimmune disease and multiple long-term conditions. I'm a public contributor. I participate in research. And recently I was part of a very small team who's been funded to do some kind of patient-led research. So I became unwell about 8 years ago and then had this 4-year diagnostic odyssey, which really got me thinking about power. And I'm not going to go into lots of details. Suffice to say that I learned very quickly that I had to curate my symptoms and my narrative to be taken seriously, because I had no power over how I was perceived by healthcare professionals. I couldn't document things in my notes, they, I would offer up my symptoms, they would choose what was important to them, and that's what they would document. So I had to learn, and autoimmune diseases have lots of symptoms. The more symptoms I mentioned, the less seriously I was taken. I was told that my illness was psychosomatic. So I had to cut back, I had to pull back and curate that in that way. And also I had to learn not to cry in consultations, because tears of anger and frustration, which is what I was feeling, are indistinguishable from tears of anxiety and depression. And again, I had no power over how that was viewed. And since then, I read, as Sarah says, a lot of narratives about empowering patients and in terms of self-management. But no one's ever said to me, Lynn, what do you need to manage your disease as well? So self-management has turned into how professionals want me to manage my disease. And things like shared decision-making, which is choose one of the options that we've presented to you. But actually, do I have the opportunity to bring options to the table? Not very often. So then, because of this experiences, this prompted my interest in patient and public involvement. And again, I sit here as one of the usual suspects. I'm white, I'm female, I'm middle class. I'm one of the people that have all the power in patient and public involvement. So people tell me, but very few people have asked me, how difficult or easy was it to become involved? And actually it was really difficult. And it was like another odyssey. So I had my 4-year diagnostic odyssey, and then I had my 4-year involvement odyssey to try and become involved. And it soon became apparent to me that public contributors are like Goldilocks porridge, and we have to be just right. But we have no power over what just right is. So if I'm applying to be involved in something, I need to think, right, what version of Lynn do they want? Do they want the Lynn that asks the difficult and challenging questions? Or do they want the Lynn that, that can come across as kind of doe-eyed and naive about research? It's all seems to be in someone else's power. And as Sarah mentioned, being held to a standard of representativeness. And I remember once applying from something, and it came back saying, yes, you've got great knowledge and great experience, Lynn, but actually you're not representative of the people that we want to involve. Okay then. And then, struggling to become involved in more. So I often don't have any powers over the terms of my involvement. So people are really desperate to, can you look at this plain English summary, Lynn? And, I once heard someone describing that as moving words around a spreadsheet. When really I want to get involved in what's your primary endpoint? What's the primary endpoint to this research? Is this meaningful to people living with this condition? What prompts are we going to use? Are we measuring what's measurable or what's meaningful? And that to me is the real nitty-gritty. And that matters because does research fail because the intervention or medication failed, or because we don't understand what's important to people living with disease, or we've measured it in the wrong way. And often in patient public involvement, sometimes it feels like the only power I have is the power to walk away and take from the involvement. And that feels like a negative power. It doesn't feel like a positive thing. And then as a research participant, and I would describe it as people wanting me to be a passive recipient of the research process, not an active participant. So I didn't even have power over whether you're going to let me know what the results of the research is. And when I've participated in a lot of qualitative research, especially in the past year, so I am offering up my insight, my experiences and whatever to someone, and then they're going away and they're interpreting that and maybe identifying themes in a way that resonates to them. But is it a way that resonates to me? And I have to trust that they will respect what I have said and understand what that means to me. And then people take that and they go away and they, you know, does my experiences not have any relevance if they can't be wrapped up in a philosophical framework or something that doesn't have meaning for me, and then written about and published in paywall journals that I can't get access to? Or if it's open access, when I read the research, can I understand it? Is it written in a language that I understand? And I kind of have no power over any of this. And it's not about individuals. I think it's about hierarchies and structures and the way that the research is set up and the publisher or perish culture. Whereas things like the community reporting movement just makes a lot of sense to me. You know, let's talk about my experiences, and then let's try and make sense of it together in a way that matters for you as a researcher, but also in a way that matters to me as a participant. And then myself and another patient contributor, Joyce, and a clinical academic, Charlotte, Joyce and I got together and we thought about some patient-led research that we would like to do. So we came up with the idea, identified the funding opportunity, and sort of half wrote the proposal, and then we brought Charlotte, who's a clinical academic, on board, and we were funded. So the application was very light touch, and it's a very small amount of money. And what I learned about this process was that I don't need to be involved in everything. And I think before I would have thought, you know, I would need to be involved in everything, and it's not. What I learned is that it's the collaboration that's important, and that it's the equality, and that the three of us have come together, and we have meetings every week, and there's nothing that we can't talk about. Everything's on the table. The power is very much shared, but within that we have different areas of responsibility, we have different areas of expertise. And that's a real learning process. And in a way, I'm going to be as excited about the process of doing this research as we are about actually what we find and kind of publishing it. And I suppose I just want to say that no one will care more about research and about the way that they navigate systems and whatever than people living with diseases. And we're here and we want to help, but involve us, don't take our power away from us, and try and do it meaningfully. Thank you.
That's absolutely fantastic. And thank you both very much. There's been a huge and very positive response to what Lynn's been saying on the chat in the seminar, and it's very, very powerful, this idea of curating symptoms and narratives in a way that can be amenable to the sense-making practices of researchers and clinicians. Really powerful, and a powerful corrective, I think, to the claims of lived experience analysis that often run through qualitative investigation of patient and caregiver experience. I think we've established in some other work that we did a while ago that the typical person with a chronic disease has neither gender nor colour nor social class, but exists only as a kind of free-floating narrative that can be picked apart in thematic analysis. So tremendously powerful kind of critique and corrective to those kinds of attitudes. Thank you both very, very much. Very grateful. So we're going to move on. Keep your questions coming in the chat and on Slido, and we'll come to those in a while. We're going to move on to Lorelei, who is going to talk to us about some equally provocative and fantastic work that she's done about how medical directors, a little known species of doctor, of hybrid doctor administrator, sort of mediate and manage and make power, the kinds of power, I suspect, that later require patients to narrate and curate themselves to fit with institutional and organisational frames. So, Lorelei, we're in your hands. Fab.
Okay, thank you very much, Carl, for the invitation and for the very kind introduction. It's lovely to be here. And thank you also to my co-author, Naomi Fulop, and to my funders, which is you. So the organisation previously known as NIHR Park, North Thames. So thank you. Okay, so I'd like to start here with my slide. It's not my slide, it's Carl's slide, but I wish it was my slide. It's a great slide. I love this slide. I particularly like the first banner in terms of this lovely definition of implementation as the translation of the strategic intentions of one group of actors into the everyday practices of others. And so whether it's a policy or whether it's a program, there's always that question of how do we actually get people on the ground in healthcare, that would be nurses, doctors, patients. How do we get people to do something different? How do we get to change their behavior, to stop doing something or to start doing something? And, you know, there's different mechanisms that you can use. So you can pay people, that often works. You can tell people what to do forcefully. You know, you can use formal authority backed up with sanctions. And that sometimes works, that's sometimes quite effective, but when you're working with professionals, that can be a bit ineffective sometimes as well, because professionals often don't like being told what to do. So professionals feel like they're intrinsically motivated, that it's part of their identity, that they want to provide a quality service. And so sometimes the use of top-down hierarchy to get them to change their behaviour can cause conflict. And it can be ineffective in organisations, and then it can cause effects that aren't that desirable. So it can stifle creativity, it can cause employees to disengage. So it has problems as well as possibilities. And what something I'm interested in studying is the way that in public services we're increasingly using different types of mechanisms to change the behaviour of people on the ground. So things that Carl would probably refer to as softer ways of getting people to change their behaviour. And they're interesting to me because they're sometimes a bit less visible than other mechanisms, and it's in that invisibility that makes them more effective. So the one I'm going to be talking about today is leadership. So medical leadership in particular, and medical leadership has a very prominent role in health policy at the moment. So you see it a lot in policy documents, and it's often assumed to be essential if you're trying to do something like strategic change. They're seen as essential for making change happen. And there's a growing evidence that actually having doctors involved in these management roles is associated with high quality outcomes. So we have some quantitative data, for example, saying that the more doctors you have in the governing boards of NHS organisations, the better outcomes you're going to get, including, you know, mortality. But what we don't know is how they're having this positive effect. So there's been a lot of research on doctors in management roles. They're very interesting to social scientists because they occupy these strange creatures, which are sort of like half manager, half doctor, and they're quite interesting for that reason. But most of the research has been on middle managers. There's been very little research done on the top doc, if you like, in organisations. And most of the research has been interested in professional identity. You know, what does it do to be in this liminal position between two different cultures, if you like? So within healthcare organisations, two dominant cultures are medicine and management, and doctors in management roles sort of sit between the two. So a lot of the research is focused on identity and the implications for autonomy of the profession. There's been hardly anything really on what the effects of these roles are. You know, what is the effect of having these hybrids in an organisation on things like policy implementation, strategic change, and quality improvement. And that's where our research sits. So it's part of a broader study on hospital boards, and I think Glenn is here, so hello Glenn. Glenn's also on our team. And this, I mean, I don't know if you know anything about hospital boards. I didn't know anything about hospital boards before I started doing this research. So hospital boards are the governing boards of healthcare organisations. That's the top leadership of healthcare organisations. And they're made up of a team of executive directors, so a team of senior managers, and each member of the team will have a particular remit. So it'll be human resources or finance or operations. And that team is led by the chief executive. The other important people on hospital boards are the non-executive directors, and they're not employees of an organisation. They hold the executive team to account, and together these two teams work together to develop strategy for the organisation, and the whole team's led by the chair. So boards are really important for healthcare and for quality improvement because of their role in leading the organisation. And if you look at the inquiries that have been done into serious failings of care in the NHS, they're often attributed to weaknesses in the board, so weaknesses in the way that the organisation is led. So that's why they're so important. So this research is a bottom-up piece of research. So it's ethnographic research focused on what Carl and Tracy Finch would call what is the work. So looking at the everyday work of medical directors. To this day, I don't know what a medical director is meant to do. I've never read an actual job description. What I was interested in is how they spent their time every day. What did they actually do and what were they accomplishing? So how were government objectives being realised every day in everyday practices? So I'll move on. What we found was that medical directors were being involved in some very important forms of work. So translation work, diplomatic work, and repair work. And this was what was contributing to quality improvement in the organisation. So as we said, that medical directors are this hybrid role, sort of sitting a bit between management and medicine. And within healthcare organisations, that hybrid role makes them very effective boundary spanners. And they play an important role within healthcare organisations, translating between different domains of knowledge and between different spheres. And one of the most important things they did in this study was translate evidence into practice. So they played an important role in terms of the data that was being collected in the organisation, the data analysis that was being done, and then interpreting that for other members of the board and pointing out things that might be significant, as well as contributing other forms of analysis to understand what that data means. So if you've ever been to a board meeting, there's an awful lot of data. There's pages and pages and pages and pages of data that's collected in the organisation on performance indicators. So things to do with, you know, finance and length of stay, mortality, that sort of thing. And medical directors did a lot of interpretation of that. In high-performing organisations, this translation work was going on. They also translated into the organisation important developments in the broader landscape, so important policy developments or developments to do with regulation. They translated that for the organisation, pointing out, you know, this is the implications. And they translated between research that was being done and being published in medical journals, for example, and then summarising that and translating it again for the organisation. What are the implications for us? And within their broader networks, in the broader health and social care system, they were locating and identifying innovations that might be useful in the organisation and then translating those into the organisations. So this is one of the most interesting bits of the research for me. This was the diplomatic work that medical directors were involved with. And much of what I'm about to talk about comes from some time I spent shadowing a medical director. So following him around and just seeing what he did every day and how he spent his time. I didn't follow him everywhere, but I sort of followed him on and off for about a year. And it was clear from doing this that he spent quite a lot of his time in what could be described as diplomatic work. So I've defined this as the sensitive and tactful dealing with doctors in the organisation based on an understanding of professional norms, professional values and beliefs. So having a background in medicine meant that he, and it was a he in this case, so if you hear me referring to Stephen, this is the doctor that I was shadowing. So what Stephen was able to do with his background in medicine was he was able to have an understanding of professional values. And so when he wanted to engage doctors in strategic change, or when he wanted to engage doctors in quality improvement, he was able to do it in such a way that it didn't annoy people too much. And he did it in a way that aligned with their professional values. And that really was key to his effectiveness at introducing strategic change and implementing quality improvement initiatives. Another thing he understood about the organisation was some of the internal politics to do with different professional groups. So different professional groups have different understandings. And this is something that really interests me. Often it's about what we know. So you could call this sort of like an ontological politics. Different professional groups have different understandings of key concepts such as health and illness. And that can be a source of tension when you're introducing initiatives and quality improvement interventions. So for example, different professional groups have different understandings of mental illness and what causes it and what should be done. And those differences can cause conflict then if you were wanting to, say, develop a new pathway in mental health. And he had this understanding of these internal politics and was able to then use that knowledge to more effectively implement quality improvement. And I'm sure a lot of people here are involved in implementation, and you'll know yourself that it's really key to understand routine working practices. It's really important that you understand the way things are done around here, and some initiatives just aren't going to work because they just don't fit with routine operations. So there are some more examples of diplomatic work in the paper if you want to have a look, but this is just one example of Stephen reflecting on his own effectiveness and how this sort of draws on his background as a doctor. And so this is me, and I'm saying, we're just having a conversation, I'm saying, so, does it help being a doctor? And Stephen replies, what with other doctors? Yeah, absolutely. It's still with some of them essential. They're not going to listen to someone who's not a doctor, and also they've got that higher purpose sort of trump card. So yeah, I think in order to move them, you do need to be a doctor, and they need to believe, and they don't always, they need to believe that you're on the side of the good guys and trying to do something sensible. So what I'm using this data to illustrate here is this cultural legitimacy that Stephen had because of his background in medicine, and also the cultural legitimacy that doctors have generally in an organisation because of their status as doctors, and how that gives them that trump card, as Stephen refers to here. So there's diplomatic work within the organisation, but there's also very important diplomatic work in the broader system. So in the broader health and social care community in the region. And much of this work involved the politics of healthcare planning. So all the medical directors in our study were heavily involved in the politics of healthcare planning. And when I think about healthcare planning, regional healthcare planning, I find it useful to think about the politics that's on the front stage and the politics that's on the backstage. So the front stage is that type of politics where we're emphasising the rationality of what we're doing. So this is a very rational thing to be doing. It's based on the evidence. It's scientific, and we're also involving the patients in doing that work. So that is work on the front stage. Planning on the backstage acknowledges much more the more political aspect of it. So the negotiation and the bargaining that goes on between different interest groups in healthcare planning. So an example of the work of medical directors on the front stage in healthcare planning is the clinical review group, sometimes called a clinical senate. So this is a group of medical directors with the task of planning clinical services across the region in a very rational way. So the medical directors in this study, when they engaged in this work, they did take it at face value. They were very interested in coming up with redesigns for clinical services. They're interested in perhaps redesigning vascular services so that, you know, if we put this bit over here, you know, that's going to be a lot more sensible if we reorganize things. And they did do that work, you know, they did take that at face value, but at the same time, they were very conscious of the fact that they were on the stage, and they often referred to themselves as being on the stage. And I think they were aware of themselves as perhaps being on someone else's stage as well. So they're aware of the way that the fact that they were doctors, and that this was a process involving doctors doing the planning, that this gave the plans for the region a legitimacy. So this is another illustration of planning on the backstage. And this is an example of using sort of more informal channels of communication. And in the United Kingdom, you're probably all very aware that when you change healthcare services, this can be contested. It can be very political to be changing healthcare services, particularly if you're closing facilities, particularly if you're closing something like an A&E department. This can be the source of political conflict and local public and community campaigns to save the local hospital or to save the local facilities. So the organisation that he worked for had plans to close some facilities, and these had been released to the press in an awkward or untimely way. And as a result, there were a number of local community protests to save the hospital. And the local politicians had also become involved because it was in the run-up to a local election. So all three local politicians had also become involved in these protests. So Stephen sort of went along to talk to the local politicians, and they said to him, you know, this does seem like a sensible thing to be doing, but you know, you've blown your comms, and so until next April we're going to save you, and that made me laugh. But I think what this does illustrate nicely is the healthcare politics, regional healthcare politics, but also an understanding really of the different roles that people play in that. So there's an understanding here that it's the role of the organisation to manage the communication of controversial plans, and it's the role of local politicians to represent their constituents' interests and get re-elected. It was quite clear from following Stephen around and watching him do his work that quite a lot of what he did was actually repairing relationships. And often these relationships required repairing because of previous change initiatives in the hospital. So perhaps there'd been cuts to services, and these had a surprisingly long-lasting effect on the staff who were involved. And it was clear, and Stephen acknowledged this himself, that for him to do much of his work, for him to, especially to introduce a new initiative, involved acknowledging previous trauma in the organisation and rebuilding trust. And he actually described himself feeling like a therapist a lot of the time in the work he did, and that the meetings that he would have with consultants in the organisation before, in the run-up to sort of introducing a new initiative, was he described this as like therapy. And this is just an example of some of the data. This is from an interview with Stephen. And he says here, you know, what the urgent care doctor was saying is, this is the 6th time in 2 years where I've been pulled out of the actual work to come to focus groups to put. So, you know, some of it is just getting people just to hope, if you know what I mean, because they're wary and they've been let down before. So he was also involved in repairing relationships again, in the broader system with other organisations in the region. We spent a lot of time doing that. And this annoys me a little bit because makes me a bit cross. Many years ago, about 10 years ago, I was doing some research on the introduction of competition into the NHS and competition between providers. And we said at the time, we said, well, no, you know, that's just going to erode trust between organisations. That's not going to work. That's, you know, that's going to damage relationships and they're not going to be able to collaborate. And now, of course, I'm doing a study whereby the medical director is spending much of his time attempting to repair relationships between organisations that had been damaged by provider competition, as well as other forms of large-scale change, such as mergers and reconfigurations, etc. Again, just some data to illustrate. One of the things that Stephen wanted to do was to introduce a clinical network for paediatric surgery. So clinical networks are a way of collaborating between organisations, for example, sharing shifts for consultants, sharing rotas. And in order to do this, he had to repair a relationship with one of the other organisations in the region. And he says here that, you know, it's taken 2 or 3 years to sort this out. So this is a nice illustration of how long it takes to actually fix some of these things. You know, once relationships get damaged, you know, how long it can take to repair these relationships. So just to summarise, I think our research contributes to understanding, you know, what medical directors are doing and how it contributes to the quality of the service provided by the organisation. And we suggest that it contributes by supporting and strengthening the absorptive capacity of an organisation. And absorptive capacity is that ability to identify knowledge in the external environment, identify an innovation, and then embed that in the organisation and benefit from it. So there's a lot of research on knowledge translation. How do you translate knowledge? But there's not so much on the diplomatic work and the emotional work, you know, the repair work that needs to be done in order to translate knowledge. I think an important aspect of the research is the way it highlights the enduring emotional effects of large-scale organisational change that often last for years afterwards. I mean, often when we talk about disruption in the NHS, we talk about it in wholly positive terms. You know, we need disruption, we need to disrupt things. And there's growing evidence that, in fact, some of these large-scale forms of change cause a disruption that makes it very difficult then to implement quality improvement initiatives. And they have emotional effects within the organisation. I mean, not always. I mean, I work for Bangor University and we're getting a new medical school. So that's, you know, that's quite an exciting change to be happening. It's something I'm looking forward to. But quite often, that sort of organisational change is associated with feelings such as anger and fear, resentment, loss, bitterness, cynicism, and all these emotions then are created in organisations, and they impact negatively on staff well-being. And it hinders teamwork, it hinders problem solving, it hinders creativity, which all then have a knock-on effect on patient care. And so this all has, you know, it's not good for productivity, and it's not particularly good for patient care. And the other thing I think we do is to present perhaps a more nuanced understanding of professional resistance. When you talk about quality improvement, when you talk about strategic change, you often talk about how professionals are going to resist what is being suggested. And it's often assumed that that's down to vested interests, and I think sometimes it is. But what we show here is that it can also be initiative fatigue, and it can also be born from previous experience. So thank you very much for listening.
Thank you, Lorelei. Thank you very much. A fantastic presentation, really brilliant underpinning research. That, I mean, one of the things that really struck me about this is that the hospital board is a place where the patient's voice gets hidden in the black box of management information. And I sort of began to wonder what would happen if that changed. Brilliant work. What I just want to say about that is certainly one of the things that we've been looking at is the role of disruption and turbulence in shaping change process, whether we're looking at implementation processes or other kinds of change processes. And I think you've given a really smart model for thinking that through. Okay, so we can move on a little bit and find Justin. Will Justin appear on my screen? Yeah, he does. So here's Justin Waring from the University of Birmingham, who's going to talk about the politics of implementing change, the politics of change. So thank you very much, Justin.
Thank you, Cole. Can everyone see the slides? Yeah. Are they there? Brilliant. Thank you. So thank you for inviting me, and thank you for the two previous speakers for really some really stimulating ideas and ways of thinking about power, involvement, influence, for example. I'm not going to engage directly with questions of power, hard or soft, or whatever theorization of power we want to get into. I don't think we've got time today to really get to the nuts and bolts of what Foucault was saying, as much as I'd like to. But what I'd like to do is think about questions of power through a focus on organisational politics or micropolitics, and I'll say more about those later. But what I'd like to do first of all is just kind of give an account of some research data that we collected through shadowing, again, a board, but this time it wasn't a trust board, it was a programme board as a part of an STP. We shadowed them for about a year, and I've kind of had to, in this account, tweak some of the descriptive features and events, largely to safeguard the people and their identities and the organisations involved. But I hope this will bring to light many of the issues that you will probably be very familiar with anyway. And then afterwards, I'll try to offer some kind of interpretation and analysis of this. So the programme board in question was established, as I say, as a part of an STP, which is, for those who don't know, a sustainability and transformation plan, partnership programme. The P keeps changing its name, and they're all going to be ICSs soon, so don't worry about it. And the board was put together to identify, develop and implement interventions to address really the demand problems for unplanned urgent care. So too many people turning up at the ED. And this was before the pandemic, when obviously some of those figures changed. And the board comprised various service level, system level representatives. So people from CCGs, local authority, adult social care, medical and clinical representatives from the larger acute hospitals, particularly ED specialists and the managers of urgent care, representatives from the large mental health acute trust, the community trust, the community mental health trusts. GP representatives were invited, but very rarely turned up. Police, ambulance, the great and the good of the care system that had some involvement in urgent care. And to some extent, all broadly agreed that there were problems. There were issues that needed to be addressed in the care system. But as you might expect, there were varying interpretations of what the source of these problems were and what the solutions might be that stem from their different views, their different understandings or knowledges about the care system, their different philosophies of care, their different ways of working, their professional cultures, their different service priorities. And I'm not going to go into all of these, but just to kind of give you a flavour, and again, these probably won't be too surprising, that the acute sector tended to point the finger at the GPs and the community sectors for not providing enough care in the community. And so all these patients turned up at the hospital door. The CCG representatives tended to blame the community and social care sectors for, again, not looking after people at home and not providing the necessary, for example, the social care to manage people's care needs in their home or residence. The local authority, strangely enough, saw the problem to do with community in the community hospitals and acute hospitals. Especially, one of the big things was discharging patients too early who had too many complex needs and then couldn't be managed and ended up in that revolving door of going back to the hospital. And the police saw that, for example, that everybody was at fault apart from them, and they were often on the front line picking up the pieces of a failed healthcare system. So the task facing the program board, particularly the leader, was how to identify, prioritise and implement interventions to address these problems in the context of all this disagreement. And it was the disagreement that is the politics, it kind of is live. But as I'll talk later, it reflects deeper political issues and questions of power. So we'll take a quick look at the program leader, and this echoes the last presentation in many ways. So that they were an experienced doctor, they had a very senior position both within their own trust but in the wider care system. They had a very positive reputation amongst multiple agencies. And also a national role in kind of education, research, all those kind of things. Their approach, in some ways, was in the start of the program board's work, was very much to kind of engage representatives and also other stakeholders in a form of open debate and dialogue about all these issues, to kind of bring it to the surface. But we were noted that they were very careful in setting the scene. They framed the debate in certain ways. So, for example, they talked about focusing on the big picture, not parochial issues. And they kept using these kind of rhetorical strategies time and time again. Focusing on shared problems and shared solutions, focusing on the data. So really trying to steer how this kind of debate played out. And the debate carried out for meetings. I mean, we were surprised about how long these kind of debates went round in circles, away days and workshops and regular program board meetings. But in some ways, it had some benefits. It really enabled the program leader and the kind of the group of people who they started to form around them to identify the different lines of interest and the lines of power in the groups. But also it allowed other people, other stakeholders to start to see where the lines of power were and also where the alliances could play out. But yeah, they had to get through this kind of debating and disagreement phase. So one idea that they started to think about was kind of, can we use more evidence or data to inform their decision making? And data, seems to be kind of the choice thing at the moment. Interestingly, patient voice wasn't very much included, and patient involvement wasn't really much included. There were two patient representatives, but again, some really interesting questions that we didn't explore could have been, how were they selected and what were they doing, and did they actually, did two people manage to represent the entirety of the urgent care needs for a whole region? Probably very unlikely. But anyway, that's a different issue we might want to pick up later. But the whole focus on data was really interesting, and they talked about kind of having some kind of dashboard, and I'll come back to that in a second. It's a popular kind of idea. But again, there was loads of debate about data. So was it the right data? Where did the data come from? Who controlled the data? How could we use the data? So the program leader, like I said, they started to form like a kind of smaller senior group, and these were drawn from mainly the CCG representatives, who, funnily enough, held the purse strings by and large in the care system. And what they decided to do amongst themselves was to invite subgroups of kind of stakeholders to go away and work up evidence cases, and proposals for what they think the priorities and interventions should be for urgent care. And it's interesting, this idea of inviting people or delegating or empowering people was an explicit strategy in many ways, and a strategy of kind of sending them off to do their homework, to come back with better ideas. But again, it was framed that find the evidence, find the relevant evidence, often clinical. There was some degree of focus on patient voice or patient experience, but also financial data, service level data. And this seemed to take some of the heat out of the debate. So it was a kind of diplomatic strategy. It moved the debate out of the room, out of the meetings. But one of the really interesting things that we found, again, through shadowing or working with some of the program leads, was that whilst this was going on, the program lead was meeting lots of the key people outside of the meeting room for one-to-one consultations, one-to-one interactions, to kind of understand kind of what the underlying issues and reservations were. In particular, they met lots of the people who usually had the dominant voice. who you would usually be the more influential people. And they met them because this group of people seemed to feel they weren't being heard like they would normally being heard. By letting others go away and come up with plans or business cases, it felt like, you know, my dominant voice isn't dominant anymore. How do you make sure that, you know, I'm going to be listened to? So there was this really careful, form of diplomatic, form of repair work perhaps going on around trying to allay these fears and keep people at the table. And during this period, the program lead with other service level representatives from the CCG and IT teams did start to work on this dashboard, which they would then, the plan was to appraise all of these different proposals. And when the groups came back with their different proposals or their studies, they were kind of appraised as a group. And it was quite interesting that some of the cases put forward that were very vocally put forward in the earlier meetings now seem really underpowered, under evidence, kind of, really open to question because there wasn't the data there. Again, questions were raised about what sort of data was needed or what was relevant. Whereas other proposals put forward really nice, analysis of what the problem is in different parts of the care system, what kind of solutions, what evidence-based interventions might work. And so this kind of informed the debate. But the debate didn't stop. Consensus wasn't easily reached. And in many ways, what we saw was this idea of trying to reach sufficient consensus. A just majority can just get it over the line. And part of this, again, involved having backstage conversations with some of the more dominant voices to kind of win them over, to kind of support proposals and deals that maybe they didn't feel completely committed to, but they thought actually they could be persuaded of. So I suppose this type of process and series of interactions is quite common. You saw anyone doing field work, particularly ethnographic field work in healthcare settings, will see this. And we studied 8 similar kind of program teams and boards, and these issues were relatively common. And I suppose the key thing is it brings to light these enduring disagreements about the problems facing the care systems and the strategies and actions that leaders face trying to implement change, but also the strategies and actions that people use to complicate change. And I think one of the key things is we tend to, and much of the literature, and I'll go on to talk about it in a second, focuses on the more proactive strategic manager trying to get change happen, but it needs to be seen from multiple perspectives. There's as much effort going into resisting or contesting or corrupting, and so it's this interplay. So what I want to do now is try to start to think about or think through that example, that one of many examples. So I suppose my first line of thinking is that healthcare organisations are complex and dynamic political arenas. And it's really obvious to think about this in terms of what we might think of the big P of Parliament, policymakers, Boris Johnson, Matt Hancock, all of that macro type stuff. But what the case and what I'm particularly interested in is what we might see as this small p, the kind of micro dynamics, the informal dynamics of influence, persuasion, negotiation, the kind of soft power that Carl has asked us all to talk through. And this organizational politics is very well developed, in the medical organizational sociology, and it typically stems from the idea that there's competing preferences, interests, and ideologies about the organization of care. Some of these will be very personal, interpersonal. Some of them will be very professional, and some of them will be much more societal or political in an ideological sense. And what's often really interesting is the way in which such politics comes to the fore during periods of change. It's always bubbling under the surface. I think that's the thing I'd like to emphasize. But when you look at some of the change management literature, Cotter, for example, it's during this period of change that these issues really come to the fore. And there's a really nice developed literature in the medical sociology and organizational sociology field dealing with this. I'm not going to go into lots, but just to point you in the direction, for example, of Strauss and his negotiated order thesis, which highlights the sense that it's not necessarily the prevailing structures or policies that determine how work is organized. Rather, it's the day-to-day micro level negotiations, trade-offs, interactions that doctors, nurses, other healthcare professionals and workers play out on a day-to-day basis. And there's also a huge, very well developed literature dealing with the power of healthcare professionals, particularly doctors, to resist and corrupt change that is perceived as challenging their established ways of working, their jurisdictions, their identities. I suppose what comes out from this again, in this last point, is that the micropolitics perspective often focuses on the microdynamics, but it often tends to explain it with reference to the broader macro ideological political tensions. And here you could draw upon the work of people like Carl Schmitt to explore the tensions or the relationship between the political and the politics, but that's probably for another conversation. And if you look at the research on improvement, the improvement science type research, these issues are very well discussed there as well. So Anne Langley and Jean-Louis Denis talk about the competing interests and value systems around improvement efforts, and the brilliant book. Glenn's on the line, so I'm sure Glenn's this brilliant book. So it highlights when you're organising for quality, the political challenge of negotiating the politics of change associated with implanting and sustaining improvement processes, including securing stakeholder buy-in and engagement, dealing with conflict and resistance, building change relationships, and agreeing and committing to a common agenda for improvement. So these are the political challenges that we're all probably very aware of. And if you look to the wider literature, again, kind of the organisational studies, management, strategic management literature, people like Jeffrey Pfeffer and Mintzberg and Cotter have been talking about these issues for a long time, about organisational politics, but political skill. And this is where I'm kind of exploring and thinking through at the moment. So the idea that the organisational power or political skill is about those activities taken to acquire, develop and use power and other resources to obtain one's preferences. And Pfeffer talks about this type of strategic leadership being beyond formal authority, so controlling resources, setting the agenda, co-opting experts, fostering goodwill, using language. The most probably prominent definition is from Gerald Ferris and colleagues, who have developed a huge body of work around this concept of political skill. And they talk about the ability to effectively understand others at work and use such knowledge to influence others to act in ways that enhances one's personal and or organisational objectives. And they elaborate this concept through the idea of social astuteness, or being aware of the social situation, others, yourself, and the relationships between all of those factors. The ability to have interpersonal influence, to persuade and shape others, the networking ability to build alliances. And one of the most interesting bits is this idea of apparent sincerity, so to appear to be sincere and genuine, even if you're not. And there's been a kind of like a backlash to some extent around these concepts, seeing it as kind of some dark art, some Peter Mandelson-esque dark art, behind the curtain, pulling the strings, of being duplicitous and manipulative. But actually, Jean Hartley is quite adamant that actually these political skills are constructive. They have a bright side for mediating conflict, for negotiating peace, for bringing about innovation and realising change. So bearing all of this in mind, what does the case that I talked about earlier on show us? How can we think through this case to think about organisational politics and political skill? And I think what the case shows us is that the programme leader used a range of different activities or strategies to set the scene, to frame the debate, to open up debate, to foster debate, and from that to read the tensions, to think through the tensions in the system, and then to perhaps to foster shared understanding. But then they have to switch tactics. They have to think about partnering with influential others. They delegate and empower others. They focus on the data. And then later they use these backstage deals and front stage debates, and they work towards sufficient consensus. But again, what's interesting is the need to see the counter strategies, the game. So you need to understand the entrenched disagreement, the coalitions of opposition to what people were trying to drive through or put forward. You need to see efforts to reset the agenda, to say, no, we're not doing it this way, we're doing it that way, to question the data. And also the really important thing that came through was the threat to walk away, the threat to say, well, we're not going to be involved with this. Go ahead and do what you want, but we won't want to be a part. And so that means recognizing and dealing with the winners and losers and trying to find some way of kind of dealing with those issues through creating, for example, win-wins. So just to kind of pull all this together, my kind of emerging thoughts from the literature through these kind of cases about the microdynamics of politics. I suppose the first is that I don't really think it's about a skilled leader influencing less skilled others, as some of the literature might make us think. Particularly the literature on political skill seems to really advocate this idea that it's about an individual who's really skilled, and it's very behaviouralist in its view of thinking about political skill. Rather, I think what we should see is that politics is manifest through constellations of dynamic multilateral interactions of not individuals but groups. And all of these actors are using a range of context-specific strategies and tactics of influence. But importantly, it's turn-taking. It's always action, counteraction, reaction, counteraction. And so what becomes interesting are not the skills of the players, but the rhythm of the game. It's like watching football. You don't want to put it on player cam all the time, because actually one player might be standing around doing very little. What you want to do is look at the rhythm of the game, because that's how power plays out. And I think the other more sociological contribution to these kind of debates is thinking about social position. The actors enter the game from different social positions, and people are in the game in different positions. So, for example, in this case, the program lead benefited from their professional status, their leadership experience, and their reputation. That justified their position and their role as the lead, but it didn't enable them to force through anything. They couldn't use coercive or formal authority. They needed to bolster their position through overt alliances and covert deals. Others also had variable positions in the field. So some of the acute doctors, you could argue, were much more significant or influential. People in the CCG had the kind of financial control. So using a Bourdieusian lens, you can see that people have different forms of capital or resource from which to drive their potential or capabilities to act, but also they had different preferences, different dispositions towards acting. And what became interesting was the way in which these interlink together through the process, through the rhythm of the game. And so I think, kind of trying to pull it all together, the concluding thoughts is that the implementing change is all about micropolitics, and I don't think there's anything radically new in that statement, but it's about thinking about change as being a controversy. And the intervention is very rarely the issue itself. The controversy is what happens when people disagree about something. So we often get focused on the intervention, but it's the people and the constellation of competing views around the person. And it's important to think beyond very narrow individualistic, behavioristic, change agent approaches to transformational or transactional leadership. Rather, it's much more about pluralized, collective leadership, looking at actors engaging in different forms of political action rather than political skill, looking at their social position, looking at the interactive order, and also bearing in mind the deeper ideological and political tensions that often underpin all of this. So I'll leave it there. Thank you.
Wow, brilliant. A tour de force through thinking about how managers manage at a regional level. One of the things that's run through all of the four speakers, to my mind, is how different kinds of controversy are resolved in these accounts. So we've heard about calming controversy, we've heard about diplomacy and repair work, and Justin's just talked about change as in itself controversy. So I hope that at some point we'll come back to that problem. So we're going to move now to the panel discussion. Well, welcome back, everybody. Lorelei has her friend with her. So brilliant to see you all. Thank you very much for these very accomplished and extremely interesting contributions to our seminar. it's interesting, isn't it, what soft power means to people. Some of the powers that we've talked about are actually not soft at all. They're quite brutal, some of them. You know, the powers of exclusion can be very very tough. So we do have some questions from the audience who so there's I want to start by just having a little look. One of our audience has offered us a question which is not so much a question as a life's work for the speakers. And I don't know who this is, but they've said, how can we best address the imbalances of power that have been presented today? Question for all speakers. So, are there, in the different analyses that you have all offered, techniques that you have observed that help us deal with these inequalities in power and knowledge and capacity to influence the course of events? I'm looking for a volunteer.
I'll start. So I think one of the things about hierarchies in the NHS is their resilient nature. Yeah. They're very enduring. These are very enduring forms of differences in power and hierarchy. But having said that, a simple one that I observed during field work was that the medical director was very aware, I think, of the power that he sort of carried around with him. And he often used what I would call strategic absence or strategic inaction. So, for example, he would not speak in board meetings intentionally, because in order to encourage the rest of the board to talk and encourage group dynamics. So he often admitted that he'd let a lot of things go past rather than comment on everything in order to encourage positive group dynamics. He would intentionally not go to particular meetings so that staff at lower levels in the organisation wouldn't feel inhibited in any way. And I could see, you know, even within the clinical senate, he often was at the top of the hierarchy, because he was a man, and he was also the medical director of an acute trust, which in the NHS sort of sits at the top of the pyramid. So, but he was very conscious of that, and would take moves to take himself away from situations so other people would get a chance to talk without him dominating.
Thank you. Lynn, do you have a thought? I'm sure you do. Sorry. What are your thoughts on this matter?
Yeah, so my thoughts, I mean, what I've written down is like open and honest conversations, because I think that, you know, if I be open and honest about what I can influence, about what power I have, about what's on the table, and then I can decide if I want to get involved in that basis. It's when we're not open and honest, and you come into something and then you're left with this terrible feeling of being let down. And like I say, sometimes the only power you have is to walk away from that. So, and I think there's a lot of kind of faux, I mean, so I've become more interested in co-production, and I think that co-production, but it's not a method. You know, patient public involvement's not a method. I'm not a method. It's looking at values. It's using values, not frameworks and whatever, and putting these values at the centre. And things like co-production, they're about a state of being, not a state of doing. And I don't know, maybe it sounds a bit Pollyanna, but I like to think that if we come together and we're all on the same page, and we know, because what I learned was it's not I don't need to have power over everything. I don't need to be involved in everything. I just need to be involved in some of the decisions around that.
Yeah.
That's what's important, not having stuff done to me all the time.
Yeah.
You know, that just gets so, yeah. So just be open and honest and be clear, and then people can decide on that basis. And I think that's a pretty good start. Yeah.
Yeah. And Sarah, you want to add to that?
Yeah, just to chime in to echo really, but very much so. You know, on that kind of phrase that it's the co-production is not a method. It's that way of doing, or way of being, or way of doing with, being with. And I think that can sound very fluffy to a lot of researchers who want a method. They want me to tell them kind of that if you do a design this way and an analysis this way, you've done co-production, or they want to know which word they should use. So is it that it's not called co-production, I should call it co-design, or is it I shouldn't call it PPI because that's not co-production, is it? And it's a way of getting confused rather than looking at what we are actually doing in the room with people and how we're being with them and what opportunities they have or not. So I think that bringing out, but that putting sunlight on it, that those issues of power would be a great first step, I think, to recommend. A lot of us as researchers we tend to immediately think, well, I don't have any power because I have to do what my boss says or what the funder says, or I have to do what the editor says to get my paper written. But we do certainly have a great deal of power and legitimacy with things we offer compared to a lot of patients, and to actually bring that into the room and debate that, I think, is a great start, is a start of those honest conversations, as Lynn has said.
Justin.
Thanks, Carl, and thanks everyone as well. Really thought-provoking, ideas and suggestions. I suppose when I think about tackling imbalances of power, it makes me think about how we're thinking about power. And I wasn't going to go into lots of this in lots of detail, but I suppose one of the things that I keep thinking or keep seeing is this idea that power is somehow an individual capability or resource, and what we often need to do is have a deficit view or a kind of a redistributive view to give people more power, to kind of change what capabilities or resources they have. And I think a lot of the training or development literature seems to be about empowering by giving something. And I think one of the things for me is that this sense of it just feels a bit neoliberal. It's a bit like if we give people more cash and more opportunities to be entrepreneurial, they'll be able to look after their own care. And the real issue I think that I keep coming back to is the kind of the idea that power is social, it's systemic and dispositional. And so it's not about giving people more capability. Maybe it's about giving people more opportunity, but it's about fundamentally changing the field of relations that we exist in and operating within society, dealing with the kind of the really thorny big issues around structural inequalities and all those kind of things. So I just kind of, I don't think there's one size fits all for dealing with power imbalances, because it operates across multiple different ontologies. And so I think, in some cases we can probably deal with enhancing capabilities or resources or skills. In other cases, we can think about giving people more opportunities to relate and engage and influence us. But unless we deal with the kind of underlying structural inequalities, it just makes me wonder how far we'll get.
Yeah, I have some sympathy with those views. One of the things that really strikes me, and I was thinking about this as I was listening to Lynn talking about curating and narrating her experiences of being a patient or being constituted as a particular kind of patient. In the work that I and colleagues have done about chronic disease management in inverted commas, one of the things that consistently comes across in the literature that we've reviewed is that actually patients and caregivers do have quite a lot of power, and they tend to exercise it by not doing what clinicians want them to do. And for which reason there's now an enormous body of literature about the failure of patient groups to adhere to different kinds of self-care regimens, which constitutes this as a failure, as a personal moral failure, or some kind of collective failure of self-efficacy, and often doesn't consider the way in which that might actually be quite a productive move on the part of many patients. So that you have this really exciting kind of set of concepts around how power is organized around views of what is legitimate for people to do and to be, and importantly, what is legitimate for them to know. And I think that's one of the things that really came across in all of your talks, was about the significance of the way in which different bodies of knowledge are defined as legitimate to inform action or to inform change. And I loved the way that Lynn was talking about co-production, and of course co-production is a very important mechanism for creating, if not legitimacy, then at least the appearance of legitimacy. So you have this sort of crisis over legitimacy that in one way or another all of you have reflected on. And I've got a very kind of practical question from the audience here about when we're thinking about co-creation. And this questioner, who unfortunately in the email I've got, I don't have their name, but I mean, I'm sure they know who they are, is actually talking about the role of particular kinds of group work, focus groups, as if you like a locus of power imbalances when they include both professionals and patients and others. And so there's a question about how to balance power dynamics. And I think what we got from Justin just now is very helpful, that actually you can't necessarily balance these contending interests. But the question is, how can we mobilize research methods in such a way that they give everybody an equal voice? Because that's actually what might be something that we could aim to do. And an equal legitimacy, which is something that large-scale systems tend to deny people that are not at the centre of their kind of their own narratives. Any thoughts on that, Sarah?
I'm going to be petulant actually in response and kind of go, but there is an assumption in that research has this something to offer in terms of actually are there methods we use which support equality. And I think the examples that myself and Lynn talked about, research is one of the worst offenders for not treating different kinds of knowledge as equal, for treating certain kinds of knowledge as only equal once we've, put them in a framework and put them in a paper. I don't think that, that's a very negative kind of response. I do actually think we do have examples within certain disciplines or certain orientations. So if you look at things like community-based participatory research, if you look at action research, there are literatures about how researchers have tried to do projects on a kind of even keel with different stakeholders that I think we can learn from. But it is in a way, I think first step would be to acknowledge, as I said, that we have a very long way to go on that ourselves.
Lynn?
Yeah, can I just add that I think that reflection is really, really important here. And I think we need to continually reflect. And what I would say to people is that if you don't feel that you can authentically share power or do these kinds of events, then don't do it. because, I mean, interestingly, I was talking about the emotional impacts, because I think the emotional impact for people that go through a process that isn't as advertised can be absolutely immense. So if it's not for you, you know, especially things like co-production, when it becomes like the latest method that everyone wants to do it, will reflect, is it for you? Can I do it? Can I do it meaningfully? Can I do it authentically? If you don't think you can, then don't do it. No. Because it's not, because you could actively do harm to people if you do. And I, you know, when I started doing it, you know, I've done a bit of co-production, but I'd say more that people have told me that I've been part of a co-produced process rather than me feeling that I actually was. And I've been doing some stuff for the co-production collective. They have a thing that, you know, when you get together, you introduce yourself, but you don't talk about your job title or whatever. And that was like a thunderbolt moment for me, because I realized that I've been going to all these, like, you know, PPI events and stuff, and I say, you know, I'm Lynn Laidlaw and I'm involved in X, Y, and Z, you know, because it's this big long list. And I thought, why am I doing that? You know, I'm jockeying for position as much as oh, you know, look at me, look at my experience, choose me, I'm wonderful, you need to have me in your team, you know, which was just totally against what this should be. So that's about, so to me, it's why it's about this reflective piece all the time, and just reflecting on what you're doing and why you're doing it continually.
And I think too, reflecting on who the other people in the room are, because these can be quite interesting. Is it just as an aside? There's been some very interesting qualitative work done about long COVID over the past few weeks, and a few months rather. And this interests me because I was actually a subject in one of those, a participant in one of those studies, because I don't have a life and I can, you know, invest my time in stuff like that. But one of the remarkable things about that were the accounts from health professionals themselves, who had suddenly been constituted as a difficult kind of patient, a patient who's not presenting with the kinds of very concrete symptoms that people want, and who struggled. And I having been involved in many studies with patients over a very long time, in which they've talked about the struggle to be believed by health professionals, and the extent to which their analyses of their own situation were not regarded as warrantable or legitimate. It was very interesting to see how they responded suddenly to not being seen as legitimate or warrantable patients, and to have complex symptoms that nobody was quite sure what to do with. And it interests me that in the national conversations about how to handle long COVID and problems like that, the patient's view has actually been incorporated quite effectively in some of the NICE documents, but not in a way that could be translated into action. And I think that's a really important part of a lot of the things that we're talking about today. The way in which different kinds of knowledge gets placed in its right place in the system so that it has been obtained. So I know that Sarah has a strong view about the idea of representatives, and I saw that on Twitter. But in fact, that's how actors are often characterized, and not just patients, but also different kinds of professionals. And Justin gave us a fantastic, I thought, case study of exactly the problems that come from representation, and the political kind of dynamics of having large groups of people who represent diverse constituencies. So I thought that kind of ran through all of your talks, and I thought it was a very a very powerful kind of part of a model of activity, right from the micro level of the experience of the patient, not or the experience of the person who has a healthcare problem. They're not all patients. Right up to high level policy making activity, policy problem solving activity, because that's what I thought much of what Justin was talking about was getting at. A couple of other questions that have appeared, and one of the problems, one of those questions is about how does, in a world where representativeness is somehow seen as quite important, how do we deal with the heterogeneity, the diversity of different groups who are struggling to create legitimacy around their knowledge, not and their experience, not as a form of well, how do we deal with people who are struggling to create legitimacy in a world where there are many different perspectives, there are many different ways forward? So I'm just going to look, and I'm going to pick Lorelei to start with that.
Oh, Carl, I'm a social scientist. I don't have answers. I've just got questions.
Yeah, well, tell me what the sources for success were for the people that you were observing as they dealt with that problem of contending legitimacies.
The sources of success.
Yeah.
I mean, there are things, you can do, and a really nice example, which isn't actually from my study, but it's just easier to use as an example. But so one of the examples I used in my talk was about mental health and how different groups, professionals, look at mental health differently. So very different conception of mental health between, say, acute care and community services. And the reason why this is important is it can frustrate them, if you're trying to develop a mental health pathway. But there was this one study which found that, well, actually just by moving the teamwork bit to a different part in the timeline, you could sort of sidestep some of that conflict. So rather than having all the professionals in the team all the time, it was a simple design solution, I guess, that was then able to progress things, and it stopped paralysis in developing this pathway. So I think, there's things you can do from a design perspective if you have the understanding of some of these politics, and that understanding can inform your design of services.
Okay, thank you. Justin, do you have any thoughts about sources of success?
So I'm kind of now oscillating between kind of being a massive neoliberal or a massive kind of Marxist radical. So, and I suppose that they represent the two kind of polar positions that we might take. So on the one hand, all things being a typical economist answer, all things being equal, and considering that everyone has kind of equal, access to the resources, there is a sense of empowerment that goes through a market-based model, although it's inherently flawed. I'm not going to go into lots of that, but the sense of what you've got to do is challenge the institutional order. If you were trying to create a new form of, a new set of relationships, a new potential, it's challenging the institutional order, and you can either do that through kind of very individualistic kind of entrepreneurial, but we know that doesn't really work. It's a different order in itself. It's the order of the market. Or you kind of have some kind of radical collective resistance, social movement type opposition or change. And I suppose if we think about the radical social changes we've seen just over the last few years around, for example, identity politics, there has been a shift in what is legitimate and what isn't legitimate anymore. And I think these are broader questions, much broader questions than I could deal with. But they're kind of, these are fundamental questions for social scientists of kind of how and why does society change? And I think there's something about this institutional work and the entrepreneurship of changing the institutional order, which more often than not doesn't actually happen, but shifting the norms and the values. And they can happen incrementally, more often incrementally, but they can happen radically and very fast. So I haven't got an answer. I'm just going to waffle social science for 5 minutes.
Yeah, I might do something like that too. But I think actually there are some important things to say about what has changed. I vividly remember a colleague of mine at a university that we shall not name, indeed in a discipline that we shan't name, at a point when PPI was just being invented as a thing, as a policy-induced thing, coming into my office and throwing a load of paper on the floor and saying, now I've got to listen to patients. And I don't think that would happen now. What would happen now, I think, is something much more subtle, which would be around, can we get the right kind of patient? Like many men of my age, I am also a patient. And my experiences as a patient and a caregiver, or the disparity between those experiences in actual life and what I read about and research, is sometimes so great as to test one's sanity. But the thing that really interests me, once upon a time I was asked if I would be the patient representative in a study. And at the time I was an NIHR senior investigator, and I said, well, probably not, best not to have me in that role in an NIHR funded study. And then there was a big debate about how I could be positioned to speak for a very large and diverse community with various degrees of disability and pain and unpleasantness. And it gave me an insight. That experience continues to give me an insight into some of the things that we're talking about today, which is that it was assumed that because I was attended this particular outpatients clinic, that I would be able to be a bridge between a set of knowledge and practice that would be entirely opposed to each other, very different perspectives that would be completely opposed to each other, and also ways of knowing that would be opposed. So the deal here was is a big cohort study. So let's think about just how much human experience can be abstracted into a confidence interval, while at the same time I felt pretty confident from a conversation that I'd had in the waiting room for that clinic a couple of months before, that a big issue was the fact that everybody was being seen behind a curtain and everybody else could hear what was being said. So there are some things about who wants what knowledge about who, and how they're going to mobilize that knowledge, and how people are constructed as possessing particular kinds of legitimacy, and the power to define who is authorized to speak on behalf of whom becomes a central part of the soft power that we're talking about. As our speakers have talked and given their presentations, I've come to see that soft power is probably exactly the wrong way to characterize what we were actually talking about. Some of this power is hard power, because it's the power that comes from somebody who can in fact decide what is going to happen to you, or sometimes what is not going to happen to you, and over whom you have very little influence, very little influence. So that's fantastic. We're coming up to closing time. I just want to say thank you, and I know everybody who is watching will want to echo me. Thank you all very much for these great presentations, these really interesting and very different approaches to how we should envision power in the clinical world, and the diversity of data and diversity of experience that you've all brought to us. Absolutely fabulous. Thank you all very, very much. Very grateful to you. And it's been a great webinar. Thank you.